uno.
Hello. Hey, hello everybody. It's Dr. Alex Earle and it's Hump Day with Dr. Alex Earle. This is the time I get to spend with you guys and answer all your plastic surgery questions. And we are here at Pure Plastic Surgery. And today, the subject for today is going to be Synmastia. Synmastia. All right. Any of you guys know what that means? Well, I kind of gave away the answer right here, right? So Synmastia means Uni-Boob. All right. Commonly known as Uni-Boob is when there's not a good definition in between the breasts. Okay. And so I've gotten a couple questions about this recently, so I wanted to go over this. So one of the first thing I want to talk about is, well, how does this occur? Okay. And it typically occurs after a procedure. It can be either a breast augmentation or a breast lift with implant, but it involves an implant type procedure. Okay. And there are some patients that are more prone to having a Uni-Boob or Synmastia than others. Okay. So we can talk a little bit about anatomy, of course. So everyone has, their breastbone here in the center. Okay. And then you have your muscle that kind of comes in and inserts upon that breastbone, okay? And when I say the muscle, I'm talking about your chest muscle, your pectoralis major muscle, okay? Now, in some patients, these insertions are right at the edge and they're pretty far away, okay? And in some patients, these insertions are quite a bit closer, okay? So now the closer these insertions are, there is a greater of a risk of Synmastia or Uni-Boob, and that's just part of your anatomy, and unfortunately there's not a lot that you or I can do about that. But of course a surgeon who can kind of see that will have that in mind, and when they go to create the pocket for the implant, not go all the way to where the muscle inserts on the sternum, but stop a little short of that to kind of decrease the chance of having that Uni-Boob look, okay? But I think a lot of it does have to do with technique. So when you are putting the implant in that submuscular pocket, you're putting it beneath that pec major muscle, and you have to be careful not to dissect too much towards the center, so you can leave a little bit of space there, and not have that risk of the Synmastia or the Uni-Boob effect. Okay. Now, some patients have the opposite complaint. They'll say like, hey, I feel like they're too far apart, and I really want my breasts to be closer. But again, if you're someone where the muscle inserts kind of right at the edge of that breastbone, that sternum here, we really shouldn't go through that insertion to try to get them closer, because then, the only thing kind of holding things in place is skin, which is not as tough, and you have much higher chance of having the Synmastia or the Uni-Boob. So I do have those patients where you can see that naturally their anatomy, their nature is to have their breasts a bit further apart, and they'll say, hey, Dr. Earle, I would really love for my breasts to be closer together. And I'll say, I can only do what your anatomy will allow me to do, okay? Because I definitely don't want to go through those muscles insertions in the sternum, because then you're going to have a high chance of having this Synmastia or Uni-Boob. Okay? All right, so that's a little bit of how to prevent it. So the surgeon needs to be aware of their anatomy. The surgeon needs to make sure that they don't dissect past those insertions or too close. If the insertions are closer together, too close to where they insert in that breastbone. Okay? Now, what happens if you already have a Synmastia, right? So then what are the possible treatments? Well, the good news is that there is a treatment for that, okay? So if you have a Synmastia from a prior procedure, you don't have to live like that forever, okay? So there are a few treatments, but it is going to be another surgery that's going to be done under general anesthesia. So there's a few things that you have to do. Number one, actually the other risk factor for this is if your implant is too big. All right, if your implant is too big, your chances for this go high. And that's why, before I do a breast implant case, I'll take all those measurements. And one of the most important measurements that we take is called the breast width. Okay? And the breast width measures pretty much the footprint of the breast. And when you make that measurement, you want your implant to be within the range of your breast width. Okay, on average, most women's breast width is about 13 centimeters. Okay, and so if you have a breast width that's 13 centimeters, you don't want to place an implant that has a width of 14, 15, 16 centimeters. Okay, that's going to be too big for that particular patient. So that's another thing to take in consideration. Sometimes we have patients that come in and they're like, oh, I want to go into the triple D range, right? I want to have a, whatever, 650 cc implant, right? And then I measure their chest and they only have 12 centimeters of breast width. Well, I'm going to say, you know what? That's physically impossible. Not only like you should not do it, it's not the right thing to do. These implants are not going to fit your body. They're going to be poking out the side. They're going to be poking towards the center. Your risk for Synmastia goes up. I do not recommend that, okay? So that's why we take those measurements. We take these objective measurements so we can make a decision as to what is going to be the best implant that's going to fit your unique and particular chest, okay? So, but say, for whatever reason, you got an implant that's too big. Well, excuse me. One of the first things that we have to do in order to try to fix this is to go to a smaller size implant, okay? So when we talk about fixing this, there's going to be several steps. Step one is typically you go to a smaller implant, okay? That way, you can actually then you can do what's step two, which is to close down the space. Okay, you want to close down the space in this central area, okay? And you can do that in a few ways. You can do that with sutures or stitches, okay? This would be kind of a little bit the simplest, more kind of straightforward way to do it. And when you do that with sutures or stitches, they have to be what we call permanent sutures or stitches, meaning they're ones that are not going to dissolve and go away, all right? So that's a very common way of doing it. And I think for most patients, that'll work. So you can do a combination of going down, so downsizing the implant, and then closing down the space with either stitches or sutures that are permanent, okay? Now some patients may require a little bit more of a reinforcement to that area, okay? Say you need like better tissue or better tissue basically to hold on to and to keep the implant separated so the implants don't want to kind of push through there and perhaps, break through the sutures or the stitches or break through the tissue. So the other option that you can add to that is a mesh, okay? The meshes, they can come as in two varieties. It can be what we call a biologic mesh, okay, or a permanent non-absorbable mesh. For breasts, we typically use biologic mesh, okay? One of the most common ones that we use is called Galaflex. You maybe heard me talk in the past about the Galaflex mesh. It's one that you're eventually, kind of incorporates into your body and it helps strengthen the tissues in that area, okay? So mesh, typically what we use is called Galaflex, okay? Yeah, this is the same mesh that you may have heard me talk about when you talk about doing the internal bra, okay? When you're putting in that mesh in that lower, kind of creating that lower sling to help hold up the implant, well, you can shift that sling there, or you can add another piece of mesh, shift it towards the midline so that it can hold the implant a little bit further out, and then you won't no longer have that Uni-Boob effect, okay? So that's the way to fix it. So typically going down on the implant, closing down the space, which you can do with either sutures or mesh, okay? Now the post-op care then becomes really, really important, okay? Because you can do this beautiful surgery, do your implant exchange, close down that space, and then if the patient, starts doing strenuous activity or heavy lifting, well, you're just gonna blow through all those stitches, you're gonna blow through all that mesh. Once again, you're gonna end up back where you started. Okay, you don't want that. Okay, so here's where kind of the patient cooperation really comes in, because you're going to have to be very, very careful. Absolutely no heavy lifting, no strenuous activity for the first 6 weeks. Okay, for the first 6 weeks to really make sure that everything really heals in and scars down. And a lot of time during those first 6 weeks, we have you in a surgical bra. Okay. And what we do is that we actually place something, it can be similar to this, but we place some gauze in the middle there so that we can create some pressure to really hold everything down and have that stick down during those first 6 weeks, okay? So I hope that makes sense. So we'll have the surgical bra, and then you'll have like a little bit of a pressure gauze basically in that midsection, pushing everything down, having it stick down, and that way we can recreate that cleavage for you. Okay? All right, and that just about sums it up, but I'm happy to answer any questions regarding the Synmastia, Uni-Boob, breast lifts, breast implants, or anything else regarding plastic surgery.
Okay, let's start with one about breast, and it's Dr. Alex Earle. Do you do fat transfer and lift to the breast? I don't want a foreign object in my body.
Right. And so, that is something that we've been seeing more and more of. There is a lot more interest into fat transfer for the breast now, combined with a lift. We've also seen a lot of patients that are coming in to have their breast implants removed, and then after doing that, doing a lift plus minus fat transfer. So I personally don't do a lot of fat transfer to the breast. I think if you're doing it strictly for breast augmentation, it's not the best procedure to do in that sense, because it's really limited as to how much you can do with fat transfer to the breast, okay? Remember, the blood supply to the breast is not as robust as the blood supply to the buttock, for example. So as you all know, I do a lot of fat transfer to the buttock region. Now, the blood supply to the breast is not as robust, meaning that the risk of the fat being absorbed or of fat necrosis and fat cysts is higher. So you have to be more conservative with how much fat you can actually transfer to the breast. Now, for the buttock, for example, we easily do anywhere between 1,000 cc's to 1,500 cc's on average, sometimes even up to 2,000 cc's per side. In the breast, you're not going to be able to get anywhere near those numbers. The most you're going to be able to do is maybe between 200, and if you have a little bit of a larger breast, 300 cc's max. If you go beyond that, you're going to run into problems with a lot of fat necrosis and fat cysts and issues, okay? So you're limited as to how much more you can add to the breast. Also, when you do fat transfer to the breast, you're not really altering the shape of the breast. So you're going to have a similarly shaped breast, but just with more volume, okay? But if you want to alter the shape, say for example you have a tubular breast, or you want to add a lot more volume to that upper pole or anything else, well, fat transfer is not going to do that for you, okay? So there are some limitations to that. And the other thing is, if you do form the fat necrosis, it may then cause some interference with your mammograms in the future, in which whoever's reading the mammogram may not be sure whether that's a lesion or just fat necrosis, and that may lead to some unnecessary biopsies, okay? So for all those reasons, I personally don't do a lot of fat transfer to the breast, but it is something that is growing, and Dr. Vidal, some of the younger surgeons here, Dr. Vidal and Dr. Wigerif, are happy to do the fat transfer to the breast. Of course, like I said, you have to be aware of the limitations that I just talked about. You can't expect the fat transfer to the breast to do the same thing as an implant would do. But if you want to avoid the implant and just add a little bit more volume along with your lift, then that's a possibility. And I would recommend that you go to our website, and when you go to virtual consultation, and then go for Dr. Vidal or Dr. Wigerif, who are the ones who are now performing that procedure.
I had a reduction and my scar is huge and horrible. How can I get this done?
Yeah, so when you do a breast reduction, the most common pattern that we do for a breast reduction is what we call the anchor type pattern, okay? So what we call the anchor type pattern, for most breast reductions, that's the pattern that we have to use, okay? And it kind of looks like that, which is why we call it an anchor, but it means you're going to have a scar that goes all the way around the areola and then vertically down towards the bottom of the breast and then underneath the breast in that breast crease area, okay? Why do we need to do that? Because a lot of times with the breast reduction, we have to lift up that nipple position, we have to reduce the areola, and we have to remove a whole bunch of breast tissue and skin and wrap it around itself to create that rounder, perkier look overall, okay? So that's the downside to the breast reduction, but believe me, I would say over 95% of patients are super happy with their breast reductions because they get a lot of relief, because they get a lot of relief in their neck and in their backs, a lot of that tension from carrying all that weight. Okay, so some of our happiest patients are our breast reduction patients. Okay, but there is, unfortunately, you can't, right? Like everything in life, you can't get, you can't get something for free, right? And so the downside is that there are these scars, and in some patients, those scars may become hypertrophic or keloid. Okay, so if that were to happen, then we have to treat those keloids. The first line treatment would be the use of Kenalog, which is a steroid. Okay, you can try that a couple times and see if that helps. Okay, but if that doesn't help, then the next step is going to be a scar revision, in which you're basically removing all the old scars, closing everything up, creating new scars, and then being very, very, very diligent from the very beginning, treating those scars so they hopefully don't become hypertrophic or keloid again. You start using a silicone-based scar cream at 2 weeks. Sometimes if you need to use the steroids early, you can jump in on that. And also there's certain laser and intense pulse light or IPL treatments that can help with the scarring as well.
Keep on breast?
Yes.
How long does a mastopexy with implant surgery take?
Oh, I mean, obviously it's going to depend on the patient, but it's usually about an hour and a half. Why do I say it depends? Well, it depends, for example, how extensive is the mastopexy or the breast lift? Is it a donut lift, a vertical lift, or an anchor type pattern, right? So the more extensive the lift part of it is, a little bit longer it's going to take. And then it depends also like how complex is the patient. Is it the first time they're having implants? Do you have to do an implant exchange or capsulectomy and all these other variables? So, things can vary for sure, but on average, about an hour and a half.
Okay. Can breast implant illness risk be reduced?
So, first of all, does breast implant illness really exist? And what is it, right? What's causing it? So breast implant illness is something that is not really straightforward, okay, in the sense that we don't really have a clear understanding of it, and we don't really have a clear understanding of what exactly may be causing it or not, okay? So, of course, there's all the data that we have so far in terms of the big research studies have not demonstrated that the implants actually cause this, are the cause of the quote-unquote breast implant illness or the symptoms that occur. So could it be that things are true and unrelated? It's a possibility. A lot of the symptoms of breast implant illness have to do with are like autoimmune type of symptoms that are very, very similar to autoimmune diseases. And when you take the population in general, women are a lot more prone to autoimmune diseases than are men, okay? And of course, breast implants are very, very popular, so a lot of women are getting breast implants. So, of course, you're going to have women that have breast implants and have autoimmune diseases, but it doesn't necessarily mean that the breast implant caused the autoimmune disease, okay? Because if that were true, then the opposite would be true, right? So if you have breast implants causing breast implant illness and autoimmune diseases, well then certainly if you remove the implant, the disease should go away, right? And that doesn't always happen. So you can remove the implant, you can remove the capsule, you can remove the capsule partially, you can remove it completely, you can do end block, all these things that are out there on social media. But when you come down to the data and the hardcore numbers, there is no correlation, okay? And you can be doing all these procedures and of course, and then the patient continues with the same symptoms. So that's a long-winded way to say that unfortunately we just don't have a great understanding of this, and therefore there's no, I don't know of any way that you can quote-unquote reduce the risk. What I can tell you is that autoimmune diseases happen whether you get breast implants or not. So a lot of women have autoimmune disease and those symptoms, and they never had breast implants. And of course there are women who've had breast implants and get those symptoms as well. Okay?
Can I add lipo to the abdomen without the etching to my tummy tuck?
Lipo to the abdomen with the etching or
without?
Without the etching. Oh, yeah. Well, you typically don't need it. I mean, the tummy tuck's really addressing that, that anterior abdomen area of it. So usually when we do the liposuction with the tummy tuck, we focus on the flanks and the waist. And so that's the area that we really want to focus on. We want to shrink that waist, we want to create that curvy figure. Sometimes in some patients they'll have these little areas of fat just underneath the breast that are a little bit too prominent. And we can do some lipo to those areas as well at the time of the tummy tuck. But because this is the part that we're already lifting up and stretching down, I don't recommend doing lipo to that central belly area because you can then run into serious problems such as skin necrosis, i.e. skin dying, which is not good, wound breakdown, and things of that nature. So you don't want to be doing lipo to this area when you're doing a tummy tuck.
Can you talk about a large gap between implants and if it can be fixed? I know anatomy plays a role.
That's right. So then that's what we talked about a little bit at the beginning. So it definitely has to do a lot with the anatomy and where that chest muscle, the pectoralis, technical term pectoralis major, where that pectoralis major muscle inserts into the breastbone, known the sternum, basically. Okay. So in some women, those muscles insert, closer together, and in some women, those muscles insert further apart. And so when you're putting in an implant, you have to respect that boundary. You can't go through the muscle to try to get them to be closer together, because then you're going to run this risk, and it's going to become a problem in the future. So you can only get them as close as that insertion from that muscle into the sternal bone allows.
With a breast augmentation, do you prefer to do under the muscle or over the muscle?
Great question. And the answer is you got to get it in between. Okay? So right now, actually today, my preferred approach is actually a third approach, which is not known. It's a newer approach and involves a little bit more, it's a little bit more technically challenging, but I think it's the perfect approach. So right now, typically there was two approaches, right? It was either subglandular, which is beneath the breast, or submuscular, beneath the muscle. But there's a layer that's going over top of the muscle, which is a relatively thick layer. It's called the fascia. And so now we can create a pocket that's what we call subfascial. So it's underneath the fascia. So you got to lift that fascia off from the muscle, okay? And so the pocket's created just beneath the fascia, and your implant will go beneath the fascia. And this creates the best of all worlds because it still has that nice protection for the implant, and the risk of capsular contracture is very low, as low as it would be beneath the muscle. But you don't have the potential flip side, which is what's called an animation deformity. An animation deformity is when you put an implant beneath the muscle and then you flex or do certain movements and the implant and the breast move around. Okay? So that's the good news. So my preferred approach for breast augmentation is what's called the subfascial approach.
How long after one procedure can I get another one? Can I get breast lift and BBL at the same time?
So not at the same time. I do recommend separating out those procedures, but you can get it about 3 to 4 months in between. Which one you do first is really up to you, whichever you want to do. But you can do your BBL and then 3 to 4 months later do the breast, or vice versa.
Doug, this is a tricky question, but
Okay.
should I include alien abduction in my medical history?
Oh boy. Okay. Sure, I think so. I mean, if anything else, it's gonna make for some interesting conversation. That's for sure.
Okay, Doug, do you recommend a BBL first or tummy tuck? I learned from your last live they should be done separately.
That's correct. And I always say, you guys saw me with a sign out there, right? I always say tummy tuck first, okay? Do your tummy tuck first. There are many advantages to doing the tummy tuck first, okay? First of all, you're gonna get rid of all that loose skin. You're gonna be able to do that muscle repair, where you're gonna tighten up the muscles and bring them together, okay? And that's gonna make for a much better result later when you do your Lipo 360 and your BBL, okay? If you do it, and then there's always that myth, right? There's that myth that people keep saying that if you do your tummy tuck, oh, where are you gonna get the fat for the BBL? That is a complete myth. Never in my entire career, okay, have I not had enough fat because someone did a tummy tuck first. Never. Zero. Okay? Total myth. Remember, we still have the entire abdomen to lipo. A a little bit more to the flanks on the waist. We still have the entire back. We still have a lot of areas that haven't been touched with your tummy tuck. So we're definitely going to have enough fat for your BBL. So do not worry about that. But the other thing we do see, if people that had their lipo first, because that skin is poor quality skin, because that skin is loose, what happens is that it doesn't retract well, and you form more scar tissue, and then it looks really lumpy, bumpy, and wavy, and it has more chances of fibrosis and scar tissue. So when you go back then to do your tummy tuck second, it becomes a lot tougher to be able to stretch that skin down. Okay, so I'm able to remove less skin because of all the scar tissue. And also it becomes very tough to get rid of the kind of lumpy, bumpy, and wavy abnormalities, okay, because it's all been scarred down. All right, and so then you're gonna have your result of your tummy tuck is not gonna be as good. So again, highly, highly recommend separating out the procedures, and highly, highly recommend doing your tummy tuck first. All right, okay, everybody. All right, well, I hope that explains this. And of course, we're here every Wednesday on Hump Day with Dr. Alex Earle. If you guys have any plastic surgery topics you want me to go through, please send us a DM, write it in the comments, and we'll be sure to tackle that next week. All right? Okay, everybody, take care. I'll see you next week. Ciao.